This is Talking Ears. I'm Juan Vasquez.
And my name is Frank Wardinger. And this is a special episode. We are continuing the Updates in Music Audiology workshop recap from the National Hearing Conservation Association meeting back in February of 2025. In this series, we are listening to edited versions of the lectures that were given during the workshop. These are not available for CEUs, but we're wanting to provide them to the community because, frankly, there's not enough of this information out there currently in other accessible formats. So we just wanted to take advantage of having all of these wonderful speakers in one place. So with this episode, we're going to continue on with two of my favorite speakers, Heather Malyuk. She's my second favorite on this episode. You might recognize her name and voice from previous episodes of Talking Ears. And then my first favorite speaker, wait a minute, what was his name? What is your name? What was your name again?
Juan Vasquez.
Hello. So what was it that you talked about with us at the conference, Juan?
I actually spoke about sound level awareness and hearing protection device verification with the perspective of the clinicians applying best practices for the musician population, which is often underserved.
Juan, your talk was arguably the most clinically focused of the entire workshop. I heard from a couple first-time attendees that this is the reason why they came, and that getting clinical information and clinical guidance was very, very helpful. So I appreciate that you represented that during the workshop.
Glad to hear that. However, I think I would argue that my favorite speaker is actually the fifth time guest on Talking Ears, Dr. Heather Malyuk, who helped bring more awareness on a music-induced hearing injury, diplocusis. Very niche and not well-researched hearing disorder.
Absolutely. And diplocusis is a fascinating and very impactful disorder. But first, let's listen to the talk by Talking Ears co-host Juan Vasquez. Take it away.
Good afternoon, everybody. I'm going to be talking briefly about sound level awareness and verification of hearing protection devices. My goal is to inform us all a little bit more on the clinical tools that we have in our everyday traditional clinics to actually inform and educate musicians on their sound level awareness, what the risks can potentially be, and what options and strategies there are to ensure that they're still working, but also maintaining the balance of protection and performance. We also have ways to confirm that ear gear that we provide, recommend, and even make for folks is actually doing what it's supposed to be doing. With verification, it's an effective way to ensure that musicians are protected in the way that they expect. The literature has long been established that because of the nature of their work, the population of musicians can be at risk from sound-induced hearing injury from what they do and how they actually do it. Often when other regulated workers are exposed to hazardous noise, they are enrolled in a hearing conservation program. But without any regulatory influence, this population of musicians tends to be unaware of the risk and oftentimes underserved. With traditional hearing conservation programs, it's really useful to evaluate the whole person. Clinically speaking, I think this can be applied for musicians as well, not just from their exposure recording, performing, rehearsing, but also other aspects of tour life, transportation, other recreational and occupational history and exposures. Certainly for the diagnostic evaluation, one can refer to the AAA consensus document. I won't go too much in depth with the actual protocol of what's appropriate, but I want to rely heavily and highlight on the education. Education can lead to empowerment. And especially with this underserved, unregulated population, this is critical, just incredibly important. Actually informing them of how the hearing system works, like how Benj puts it, how it actually breaks, and what we can do to avoid and manage the risk, as well as manage any music-induced hearing injury. As with most hearing conservation programs, it'll start with noise monitoring, providing musicians with the accessible options and education of how sound can influence their ears, not just their ears and their hearing, but influence their lifestyle, their well-being, and how they're actually making music. Providing them with several options, helping them understand this time intensity trade-off, as well as reviewing NIOSH and OSHA standards can be helpful, But it's also important for us to acknowledge that NIOSH and OSHA regulation standards are based off occupational, construction, military sounds, not music. Music being the actual art, the sound that is produced. It's intentional. The standards are a little different when it comes to music, but it can be a really nice guideline to actually help folks better understand the risk. So we can incorporate applicable and accessible metrics for their exposure levels. There are several apps, the NIOSH SLM app and the Decibel X app. Very, very useful. It's free, and it's something that they can just pull their phone out. But there's also accessible sound level meters. This being a very inexpensive option, as opposed to pulling their phone out, they actually have something that they can use to evaluate their space, of how loud the rehearsal space is, maybe even the floor wedge. Here we just have a few examples of how we can actually measure someone's musical surroundings and inform them that higher the level, the more likely they can be at risk of their ears actually changing. So now that we're able to inform them of their sound levels, and because of that, that can lead to injury, what can we do? Oftentimes, for musicians coming into our clinic, we can approach a little differently. But in doing so, we want to make sure that, again, we balance protection and not interfere with their performance. So typical solutions, like other occupationally exposed workers, can be very different, especially with this population. They need to hear specificities in what they're doing, timbre, harmony, timing, things like that. So assessing the musician as a whole person, evaluating their instrument, their role within their ensemble, various different settings, this can help us to lead to a much better recommendation of what would be appropriate. Sometimes a musician might come in with concern of their career, their longevity. Maybe they already acquired tinnitus. They don't want it to get worse. So we want to discover options to make sure that their hearing is as intact as possible. Sometimes they may not always be necessary, but it's important to go through a thorough case history to evaluate and see what areas of their life they can actually use hearing protection. When it comes to devices, there are several options, some things that can be passive, active, universal, or custom fit. We need to account for their listening needs, and this is no exception. Through a collaborative solution, it can be as simple as having a conversation with musicians, heavily dependent on case history, of course. We need to make sure that we account for the balance of protection and positive perception of performance. It's like the 4 Ps of music, hearing protection devices: protection, positive perception of performance. Additionally, safe listening habits, just reducing sound exposure whenever they're not playing music or around music. Even something as simple as auditory rest can be a really nice introductory step to prolonged hearing wellness. As we can see with education, self-efficacy, and motivation to use protective ear gear consistently and correctly is urgent and critical for the success of someone voluntarily incorporating hearing conservation efforts. To confirm that any selected hearing protection devices that we're helping to fit, we can actually, through simple clinical tools, verify and actually obtain quantitative, objective information on making sure that the hearing protection device is doing what it's intended to. Orientation, of course, on the proper use, maintenance, making sure that the filters are still intact, there's no degradation of the material of the hearing protection device. Very basic, very simple. Of course, audiometric monitoring, can't stress that enough. The hearing test, always do the hearing test. Our friends down in Australia have also provided us with the MOSI, very similar to the COSI, the musician-oriented scale of improvement. And for this, it is a way for us to identify goals for what they want to get out of their hearing protection device. First, the client will list the environments in which they need or wish to use their hearing protection devices and what they want to achieve through the use of their hearing protection. Maybe not hear their tinnitus after rehearsal or performance, making sure that their hearing doesn't change. When it comes to verification, the real ear attenuation at threshold procedure, direct recommendation from the AAA consensus document. This is the recommended process for assessing the effectiveness of any hearing protection device, particularly those for custom. Known as the gold standard for measuring the amount of protection the user is getting from their hearing protection device. What we do first is acquire their ear threshold, unprotected, minimally 250 and 4,000 hertz, and the recommended dB step 1 to 2 decibels to be a little bit more precise with the effectiveness of the hearing protection. When we acquire the unprotected thresholds, fit the hearing protection devices in, and repeat those thresholds. The difference will equate to the attenuation that the hearing protection is giving. For the lower frequencies being used, it's helping us identify the check for any presence or absence of any slit leaks to ensure that there's good isolation, and for the higher frequency, to verify the specifications of the filter or even attenuation. We can do the REIT test easily in our clinical environments, circumaural earphones or sound field. If sound field is being used, important to ensure that the head position remain still, constant, and warble tones or narrowband noise should be used. Next to that is circumaural earphones, not recommended for supraaural. Additionally, there's this alternative to measuring the REIT, taking a probe mic measurement in the ear canal for earplug attenuation. Quick and objective, but also prone to slit leaks. There can be artifact using a probe tube, but it can be utilized as well. Why verify? Best practice, gold standard for fitting and the orientation of any recommended hearing protection device. This can lead to increased satisfaction as well as trust between the clinician and the client. This quantitative information really gives us the solid idea of what we're actually recommending is doing what it's intended to. A huge thank you for Dr. Portnev, Dr. Santucci, Dr. Malyuk, Dr. Flieger for all their work.
The next talk is by Heather Malyuk. I just want to say a couple embarrassing things to Heather, just to make her uncomfortable before she talks. But I've said this before, that any project that Heather is involved with, I will sign on to immediately, because good leadership, and you just follow it because it's going to succeed and it's going to be great. So if she goes, hey, I have this project, my answer is yes, before you even keep talking. And I think a lot of us in the room kind of have the same feeling. And then I was just reflecting when I was thinking about this, that so many interesting things in my professional life recently have been things that you were asked to do, but you were too busy. And then you just reached out to me like, hey, do you want to go talk at this state convention in, where was it? Seattle somewhere? And I'm like, sure, happy to. They asked you. They got me. Sorry. You were asked if you could teach at Wayne State University, their hearing loss prevention class. And you said no, but maybe Frank will do it, right? It's like maybe, maybe Mike will lead it. And that's kind of how it feels, right? I'm actually kind of surprised I haven't cleaned the leaves out of your gutter or something at this point, because I'm going to do it, yes. So, if you have a problem. A good example is actually tuned. So a couple years ago, you came to me with this really interesting thing and said, could you join this working group to talk about this interesting project for telehealth, which is the next thing we're going to talk about today? And the answer is yes immediately. And I'm so glad I said yes, because it's been such an interesting project. So anyway, you're going to talk today about one specific hearing disorder that we don't talk about a lot. We talk a lot about tinnitus and hearing loss, and we even talk a lot about hyperacusis, although it hurts the people's ears when we talk about it. Sorry, I didn't write that joke down, but I wrote these jokes down. She's going to give a pitch-perfect talk about diplocusis, and it'll be really in tune with the rest of the workshop. So it'll be sure that it resonates with our audience so acutely that it, wait for it, hurts. So Heather Malyuk.
Well, it's tough to follow Dr. Wonderful, but I'm going to try to do it. I want to preface today by saying I never thought that I would be speaking with you about diplocusis. And I'm certainly not an expert. I hope the end of this will be a discussion where you guys can teach me something. But let me tell you how this happened. Several things happened in the past few years, one of which is I had 2 children, and I'm trying to do more telehealth so that I don't have to go into an office. The second thing is I started a close working relationship with Dr. Nina Kraus at Northwestern, and she started referring all these diplocusis patients to me. And I tried my hardest for probably 5 or 6 months to try and find a provider who would work with them, and I could not pawn this work off. So I had to do it. So here I am, 2 years later, I've seen probably 10 cases of diplocusis. Of the 10, I've been able to help like 6 or 7. And so what I'm gonna do today is just walk you through what I've done so that you can do it too, and I don't have to do it anymore. So here we go. That's the goal. So we're just going to talk a little bit about the history of diplocusis, a bit of a review, and then I'm going to walk you through 2 cases. Diplocusis is not new. I mean, it's been around probably since the first ear was around, but in the mid-1800s is really where we start to see it mentioned in papers. I really like to read old literature, and I feel like a lot of people don't read enough of the really old literature, and there's a lot we can still learn from these old papers. The term diplocusis came around in the 1890s. I don't have that paper. I would love to see it. The 1930s, that's when neural pitch perception really started to be discussed and auditory processing. And then it wasn't until 1940 that we started to see classifications of diplocusis and discussion of management. And during that time, there are a couple papers that reference severing the 8th cranial nerve. So a surgical intervention to try and help these folks. And that I don't think that should be done now, but we're going to talk a little bit more about that. So in 1940, we start to see these what I call historical classifications. Typically, when you get somebody emailing you with diplocusis, they're going to use one of these terms because they saw them online. So they've gone to some audiologist website, there's an essay about diplocusis, they've seen one of these. What I want to say about this is I think it's important that we keep these, but I think those of you who work with diplocusis realize you can't just put somebody into one of these buckets. That's not how it works. And often it's really hard for a patient with diplocusis to tell you everything they're experiencing. And so one of the things to do if you're trying to figure out exactly what they have is meet with them either in your office or via telehealth like I have and sit with them for an hour and play music. Those of you who are interested in this, I have my email address up at the end. I have a really fascinating recording from a pianist, not one of my cases today, where he sat and recorded for probably a half hour, and he talked to me into this recording the whole time and told me exactly what he was hearing, exactly what he was experiencing, and it's really fascinating, and I would be happy to share that with you for those of you who want to dive into this. In terms of incidence rate, diplocusis is not studied a lot, and what we see from the general population is around 10 to 15%, and then I'm using myself as a reference for some studies I've done in the past couple years, unpublished, finding 4 to 8%. I think that this is underrepresentative. And I think one of the reasons I think that is because in the general population, you often hear people say sounds are distorted, speech doesn't sound right, and they're not going to tell you like this certain pitch is off and I have diplocusis. But on the other hand, in the music industry, those of us who see so many musicians filling out our intake forms, you also get a lot of people who think they have it and they don't. And I think we see that especially with the music cares population, where people will check the box for diplocusis and you start explaining what it is and they go, oh, no, I don't have that at all. So I think more work needs to be done in this area, so take these with a grain of salt. In terms of, where does it come from? I think, again, one of the things that you have to keep in mind with working with the music industry is that these are actually real people. They're not just musicians. They get dismissed a lot because they're exposed to sound. But an example I have from Ohio, from where I'm from, I have a local musician I work with diplocusis. He's a classical guitar player. He really hasn't had much exposure, but he's a cancer survivor. And he has quite a bit of hearing loss and issues from chemotherapy. He has been dismissed by other providers as soon as he says he's a musician. So our job is to say, well, what else is going on here with you? Perhaps middle ear pathology. This one is quite controversial. I'll get into more of that on my first case study. Central disorders. Someone's had a traumatic brain injury or a stroke. That can actually cause diplocusis. And then there are quite a few papers out there about diplocusis post-cochlear implantation. Okay, so these are kind of the main categories. Now, when you think about music industry patients and being exposed to sound and what might cause it, if you look back at papers from the 60s where they were allowed to actually induce temporary threshold shift, which we're not allowed to do that anymore, which in a way is great and in a way is a shame. But in 1963, Ward was inducing TTS and then measuring what he called a pitch fatigue below 100 hertz. And what's fascinating about this is many people with diplocusis reference 100 hertz, 200 hertz, right around that area. In the 1960s, in the mid-60s, there was a paper that a lot of people reference saying that diplocusis tends to shift pitches upward. I don't know if you remember this, Mike, but there was a day in clinic where I said our audiometer's broken. The low frequencies on the left side, I was doing a biologic check, and I said they're flat. They're like a half step flat. This is crazy. We can't see patients. And he came in and put the headset on. And he said, you're crazy. Everything's fine. And I had a very loud gig at the House of Blues in Chicago the night before with a loud wedge. And anyway, I lost it. I cried for like 10 days, remember, until it resolved or I got used to it. Long story short, mine is flat. And probably if I asked everybody in this room, yours is flat too. Okay, so modern literature talks a lot about, it's going to be sharp. But when you actually talk to patients, it's not the case. So I'm just setting the stage here that it's the Wild West when you're dealing with diplocusis. When someone sits down with you, again, look at them as a person, not a musician. I know today's about music, but put that to the side for a minute and try to discover any underlying cause here. Do they need medical intervention? Should you be referring on before you start talking about management of diplocusis? Do they have hearing loss? Do they need amplification? Or maybe they already have amplification you can work with. I'm going to talk about that on the next slide. Can they go right into auditory training? Or maybe they can't. Maybe they need some more mental health help before they see you. And I have another clinical example of that. I work with a lovely man in an orchestra in the Midwest, and he struggles with tinnitus, hyperacusis, and diplocusis. He is at risk of losing his job at all times if he has a flare-up. And I couldn't handle it. It was out of my scope. And I said to him, I want you to find a therapist near you who you really like, and then send me that man's email address or woman or whoever it is. It was a man. So I think that you should do this, is why I'm saying this. Meet with them. I had a Zoom conversation with this therapist for a half hour with my patient. The three of us met together and we discussed what these things mean to him as a musician and his identity. And that therapist was so grateful to talk to someone who understood that realm. It really influenced their care and really helped. So your role sometimes as a music audiologist is just being a facilitator and saying, let me give you some insight so that you can help this person. I think that's really important. And maybe they have another condition that you need to handle first. Maybe they need masking, sound therapy, TRT, whatever, to deal with tinnitus. Often people also have tinnitus when they have diplocusis. Okay, so just a note on the use of hearing aids. When you read about fitting hearing aids for diplocusis, it makes it seem very easy. Just notch it. Just take that frequency response and notch it where the most annoying frequencies are. I have not found that to be successful for musical inputs. But with this patient population, I have found that when we do that, they have better speech understanding. And I don't have literature to point to for that. I'm just telling you my experience. They often say, I still can't play my guitar, for example, but wow, I feel like speech is much clearer now. So you might want to do that just for their quality of life. So let's dive into case studies. I'm going to present two, and they're going to go pretty quickly. The first one, we've got a 50-year-old male full-time film composer. This guy's the real deal. I'm going to probably say this wrong. He has ankylosing spondylitis, an autoimmune condition that's been controlled for 47 years through diet, his whole life. Now, I realize that blood pressures are probably going up because I put COVID vaccination on here. I realize this is controversial. This is from his physician, not from me, okay? He had his first dose in June of 21, and almost immediately his autoimmune condition skyrocketed. And unfortunately, it hasn't stabilized quite yet. It wasn't until October he woke up with sudden tinnitus and fullness in his right ear, and he had his second vaccination in December, no issues after that. So in the physician notes, they do think the vaccination was related to the autoimmune condition skyrocketing. I don't think it's related to the hearing issues, except maybe secondary. So I just want to put that out there. December of 2023, he had his first ever COVID infection. He was positive for 10 days, mild symptoms, really bad congestion, he said. Okay, so there's our first thing we want to keep in mind. In October of 2021, he went to an ENT, had a test, his thresholds were within normal limits, and they shrugged and said, you're a musician. You're a composer. Of course you have something wrong with your ears. And be on your way. That was it. He tried telling them that his issues were below 200 hertz, and he could not work. He was having a really hard time in the studio working with this condition, and eventually they resolved. This is the second thing we want to keep in mind. Hey, his diplacousis fullness, this was able to resolve. That's interesting, isn't it? In January of 2024, this happened again. Sudden fullness, tinnitus, diplacousis, and you can see his thresholds here at that time. This was sensory neural. The treatment at that point was 2 weeks of oral steroids, 12 sessions of hyperbaric oxygen therapy. His thresholds resolved, his diplacousis did not, and he said voices sounded robotic occasionally. So this is something else you will see with this patient population. They might say voices are echoing, or voices sound fake. There's a weird quality to the acuity of things. They gave him a second round of steroids. Diplacousis resolved again, without auditory training. June 24, fullness again. Okay, so we're seeing a pattern here. He's having this up and down with his ears. They gave steroids again. The fullness went away spontaneously. Thresholds resolved. After steroids again, the diplacousis resolved. He's miserable at this point. Okay, so that's when he contacted me. I'm looking through all these notes and all these results and noticing they did bone conduction, but they didn't really investigate the middle ear very much. I don't know how things are done in London, really. I'm not sure what he had access to. And he kept saying to me that he's dealing with all this sinus stuff and this congestion ever since he had COVID. I think a lot of us who had a bout of COVID can say something's not the same. Like it feels like something's always lingering, right? I happen to have just read a paper from the 1920s that discussed conductive diplacousis. You will not see this in the modern literature. And in fact, a lot of the modern literature says that conductive diplacousis does not exist, that it has to be some kind of cochlear injury. But in my mind, it stands to reason that if you are stuffy on one side and a signal is coming at you and it's delayed on one side, gosh, you might have a problem. And so I just walked him through that. I sent him some literature and I said, can you go back to the ENT and say, do we think something conductive's going on that's lower than what you're measuring? He didn't bother doing a test with him, which I was a little angry about. He just gave him nasal spray, and guess what? It cured it. The diplacousis was gone. I've checked in with him a few times, and he gets flare-ups, and he does his nasal spray, and it cures his diplacousis, and he's working now. Okay, I didn't do a thing. All I did was sit and talk to him and not dismiss him, and I helped him walk through what he was dealing with. And you're going to see on the next case, I didn't do anything either. And you can do it too. We're going to do nothing together. So all I did was look at this like a music audiologist would and say, what's the simplest thing here, and how do I get out of doing auditory training with you? And this is where we came, and thank God it worked. So I'm very happy for this man. So we have a 72-year-old bassist, professional, and I'm going to read you this quote. This was in the first email that he sent me. He said, I've been increasingly frustrated the last 2 years by the complications that result from hearing pitches differently in my 2 ears. Efforts to discuss these issues with my regular otolaryngology/audiology people have been met with a collective shrug. Likewise, I've had little luck searching the internet for relevant resources. And he said, I don't play anymore. And at this point, he hadn't played for probably almost a year. And he was really quite depressed. Very smart man. He got himself a tone generator. And this is what he described to me. At 110 hertz, there's that low hertz again. Isn't that interesting? A tone presented alternately to each ear was perceived as a higher pitch in the left. Not much higher, less than a semitone, but it was enough to destroy him while playing. When he presented the tone to both ears, it sounded muddled, so he couldn't hear a clear pitch. And then when he presented it below 110 hertz alternately, it was perceived as being lower in pitch in the left. So he's dealing with higher, lower, everything. He was quite a severe case. When he was listening to open intervals, they were sour. He kept using the term sour or out of tune. Here are his test results. So we're looking at some low frequency loss in the left ear, moderately severe to severe in the highs. But what's really interesting about this is how many music industry professionals do we see all the time with this hearing, and they're working and they're fine and they don't have any disorders, and why does he get diplacousis? I don't know. That really fascinates me. Or thresholds could be within normal limits and they're experiencing diplacousis. So just because you see an audiogram like this doesn't mean you're going to be dealing with a hearing disorder, is my point. He wears hearing aids and loves them for speech. So you guys know what the 3D ME is. I use this tool a lot for musicians with hearing disorders. I'm going to mention it here for diplacousis and show you how we used it. But for those of you who are new to in-ear monitoring, I often use the 3D ME in the cross mode for people who have a hearing disorder just on one side. And they'll cry. They'll sit in your office and cry. It's like a godsend. And I wanted that to happen here, and it didn't happen here. I had 2 people prior to him with diplacousis in one ear, and we were able to effectively use the 3D ME in cross mode for them to play and get back to working while we still trained the ear. I'm not saying don't do auditory training. You don't want to deprive an ear or let it go. I'm just saying get them back playing. It didn't work for him. When he did it, he said, this must be more in my brain than I thought, because he kept referencing his left ear, but it didn't work. So I said, okay, let's try notching the 3D ME. We had previously, his home audiologist and I tried notching the hearing aids. And again, didn't work. But this is what we came up with for the 3D ME. It took us about 45 minutes to get to this point, and let me tell you how we did this. This is painstaking. If you're someone who says, I could never work with a tinnitus patient because of how slow the process is, you probably don't want to get into this. We sat with a keyboard and his bass and an amp, and we sang together via telehealth, and this is where we got. And it's pretty incredible when you're doing this. I had a 3D ME on my side, and he had his, and every change we did together. So I knew right where he was. We didn't do anything without me saying, stop, show me your screen, whatever. When we hit this point, it was like something opened up. And you'll notice that. It was no good, this isn't working, no good. And we hit this, and he goes, oh, that sounds pretty good. Something's helping. Let's stay here. So we saved it, and then we started what I call the Malyuk protocol, I guess. I call it play with a purpose, but let me tell you why it's play with a purpose. The goal of this was not really to train the diplacousis. The goal of this is to get the instrument back in their hands. Because he wasn't going to play on his own, I had to make him play. And so I gave him something to do. So I said, here's what we're going to do the first 2 weeks. And I had done this with people previously, and it worked. And so this is why I did it. I said, with the 3D ME, feel free to play around or go back to the previous setting. And just so you know, he always went back to where we put it. That just happened to be the magic spot for him. I said, I want you to play 10 to 20 minutes every day of simple melody lines on your bass. So he's electric only. He doesn't play upright. So he's got his bass and his amp. Include some broken and simultaneous octaves and attempt 2 to 3 musical keys per day. I want you to get to 4 keys, ones that you play frequently. Don't pick anything weird. And one thing that I had him do that, again, had worked with others, say you're playing an octave, an open octave. Play middle C, I want you to sing the octave above before you play it. We're going to trick your brain into hearing the pitch before it comes through your ear. I have yet to see this in the literature, but for some reason, individuals with diplacousis sing in tune and don't hear the issue as badly. And I don't know why, but that's been true of almost everyone I have seen. Including the man I said sent me a recording. He can sing perfectly in tune, but he cannot play the piano or anything else. It's fascinating. All right, so 2 weeks after, he checked in with me, and he said he's playing 20 to 30 minutes per day, which is wonderful. Every day, he ended up with A, D, E, and G for his keys. He said A and D sounded pretty good. He almost felt ready to go back to like a jam session or band rehearsal at this point with just those keys. But E and G, he said, were a wreck. They sounded sour. He can't do it. He can't stand it. And he said the 3D ME, he can't do it without. Something that I always try is take the device away and see if you can do it without the device too. See if we can just get off of everything, but he couldn't. And that's okay. So weeks 3 and 4, I told him to now introduce a recording and play along. This is crazy simple, isn't it? And then I said, just play the root notes of the chords. And then the next 2 weeks, I want you to complicate the bass line. Okay. 2 weeks after this, here's what he said. Every note from the lowest A up sounded reasonably good. Unison octaves played chromatically up the neck sound pretty close to in tune. Some notes were still shaky, but it finally sounded like music instead of just a smear. And he said for the first time in a long time, he felt like he had the chance to enjoy music again, recording, playing, listening. And I said, you're graduated. Done. And I've checked in with him a few times. But one of the things I always say to patients when I do some kind of training with them where I know it's going to be a series of appointments is I say something that music teachers always said to me growing up when I was taking lessons, which is, my goal is to teach you to teach yourself. My hope is that you don't need me. So we're going to go through some sessions together and then you're done. And so he's continuing to improve. He has kept this protocol up. He continues to do those first 2 weeks of basic exercises still consistently because he feels like it's going to the gym for his ears, which of course it is. So again, what did I do? I didn't do anything. All I did was sit down with this man and talk to him. I didn't dismiss him. I understood where he was coming from, and I understood his heartache. I always say in a situation like this, he basically went through a divorce with music, and my job was to get him to renew his vows with his instrument. And that was the whole process we went through together. One of the things I did that I didn't mention, I sent him a lot of articles, and I realize sometimes when we're working with patients, we think, oh, we don't want to send them literature, it might be above their head or whatever. I'm not like that. I send it all. So even those studies I referenced from the 60s, I sent him a bunch of stuff and said, I want you to read. You're in charge of your body. The diplocusis is not in charge, and we're going to demystify this whole process. I guided him back to his own instrument. The only thing I introduced was the 3DME. So it's not like we had a bunch of new tools to work with. And he was able to maintain that connection to his instrument. So on that note, I'm just curious if any of you guys have questions.
This is Frank in the future again. At this point in the talk, Heather had a question from the audience. I will paraphrase because they could not be heard on the microphone. They asked, in simple words, can you explain what the 3DME product is?
The 3DME is a active ambient in-ear monitor system that has a 7-band EQ in an app where you can EQ the mics that are on the outside of the system. It can work as tunable hearing protection, or in this case, I tried using the contralateral routing of signal function, which did not work for him. But then to go back to this, that's what the app looks like. And this is how we had it set. Anyway, just to kind of wrap this up, I think these people are fascinating. And one of the reasons why I wanted to take it on and start doing something is because they are, of all the people in the music industry and all the disorders, this is the one that is most misunderstood and most dismissed. And it breaks my heart that the field of audiology does not help them. And it broke my heart that I couldn't find somebody who does this. And so I think we all need to start because they need us. This can be as severe mentally as tinnitus or anything else, and they deserve our care. Thank you.
Talking Ears is a production of Earmark Hearing Conservation. The theme music is by Scott Hallam. You can find more of his music at audiodowsing.com. The show is produced and edited by Juan Vasquez, Scott Hallam, Mary Kim, and myself. Thanks for listening.